Well, this panel has really summed it up quite well, but I was thinking, we're entering into an age where we're dependent on big science in a resource-poor setting. We don't think of ourselves as a resource-poor healthcare system, but in terms of being able to carry out big science, we're relatively resource-poor, and projections are we will be for quite some time. So big science in that context is the science of conflict, because the only way to do it is through collaborative relationships, and those collaborative relationships need to cross sectors. And those collaborations, by their very nature, are the very relationships that we have been thus defining as conflicts of interest. So unless we're willing to kind of go out and aggressively join forces and reset the stage and say, these are really relationships and alignments of mission rather than conflicts, we are not going to be able to carry out the science of the hard stuff, really carrying out the science that's needed to get those residual cures, those things that have been hard to achieve, done for patients. So we need to think about how to do that. The other thread that's in my mind is this use of the information of the relationships. How do you get the information to the people who need to use it? How do you disclose in a way that's useful? We had a very interesting presentation recently from an organization called Wiser Together that tries to give patients information. They call themselves the eHarmony of health information. And their whole premise is they go out and mine both patients and providers who have been patients. So for example, the pregnant OB-GYN, and ask them what treatment choices do they make in certain situations. And then they summarize their demographic information and make it available. And as a patient comes in with a pressing treatment question, they match them to patients who have similar values and similar backgrounds and say, in this situation, these are what these patients and these providers who found themselves as patients chose. And they also, at the same time, provide them the evidence-based information and the coverage information. So it's a very interesting kind of triptych of information. But what I thought was missing from that confluence of information are disclosures of relationships. So maybe there's a way for us to think about how do we get all the different factors that people need to make a decision to them at the right time in the right context so they can balance them and see where that information is valuable and where it really doesn't matter to them. And it's not just for the patient, it's also for the regulator, for the academic investigator who's trying to decide if this collaborator is really a good collaborator to work with. We need to think about who needs information about those relationships and in what context do they need them and how can we deliver it to them most readily and usably so that they can really start to utilize the information that's available.